putting that in a subtle manner. And the reason is there's just such a vast amount of drugs and situations that you need to focus on. I thought a review would work because it would help you guys focus in. Now, I have asked Dr. Gupta to come in and review her section. Is that, Alexi, what do you think? It's taking a decision either right now. I called her in at 11. Do you guys want to wait that long, or would you rather not?
Can she come, what time do you think you'll be done? Around 11 or?
It'll take me about 45 minutes.
Oh.
We could go faster, I mean, I'm just saying.
All right, class, you guys want her to come? Yes,
You want
raise your
Dr.
hands.
Gupta to come for
She's
her
writing her questions.
bone metabolism. She is writing her own questions.
Then yes.
Not that.
Well, let her come. If people don't want to stay, then they can leave. So, yeah.
Okay, all right. Most of these items that I've taken are from my own slides, but it shows you where to focus in when studying. I don't have the I'm not going to talk to you about the mechanisms of actions, but I will tell you that this is something that you should be aware of. So if you have your clickers ready, I'm just kidding. No clickers ready. You should get this as bonus attendance, right? So,
I agree. Yeah.
Monday's exam, I did receive some emails from students asking the time of exam. If I'm not mistaken, I think we're still at not 10 but 9:30. Is that acceptable to everybody? 9:30 is good, and it's an hour and a half, so you'll be done at 11 on Monday next. I know this week is crazy, but that's your last exam, right? On Monday.
Are we at 9:30?
Sorry?
Are we at 9:30 we start?
I think so. Why?
The block is from 7:30 to 9:30.
Yes.
I'd rather have 9:30 than 7:30.
I'll confirm that. Okay. Yes, and that's what the student asked me. They said, are we starting at 7:30? They wanted to know. And I said, not as far as I know. I think I spoke with Ms. Square. So would you prefer 9:30 time if it works?
Yes.
You prefer 7:30?
Definitely. No.
Okay, here's what I'm going to do then. Because I'm not going to leave it. I'm not going to leave this to my decision.
Why would I want to be
Whatever
half
Ms.
asleep
Squares
when I take
has
the
put
exam?
aside, that's going to be the decision. Because we need the special functions hall. I know there's an exam, not before, but definitely after. So if there's an exam at 9:30 or 10 or even 11, and I know Dr. Swati Chitre has something happening that day. If there's an exam, in that case, then we're stuck at whatever time we're stuck. Okay, I will confirm that today as an announcement to the entire class. So the topics covered are the endocrine system, which has some basic physiology. I, as always, say the physiology is very important, but don't spend too much time on that area because it is just to establish the pharmacological knowledge that I want to give you. The two important diseases are thyroid diseases, both hypo and hyper, and diabetes. Those are the two main endocrinal diseases as far as I'm concerned. Dr. Gupta will come in and she was to talk about bone metabolism and the likes. Know those pituitary secretions in the physiology portion. Know the anterior and the posterior pituitary. Know that the posterior pituitary does not itself manufacture any hormones. What is the posterior pituitary, by the way? What is it an extension of? The hypothalamus. The posterior pituitary is an extension of the hypothalamus. So if ever, even in a board exam, you heard enough of that on Saturday, even in a board exam, if you're ever asked what are the secretions of the posterior pituitary gland, they're the secretions of the hypothalamus. So when you talk about oxytocin, pitocin and ADH, anti-diuretic hormone, those are just stored in the posterior pituitary. They are manufactured by the hypothalamus. But the anterior pituitary has some important hormones, growth hormone, prolactin, for mothers who are young mothers and they need milk let down for babies. Also, there are 4 tropic hormones. Know that word, tropic. Tropic means hormones that are in charge. They regulate other hormones. So those are called tropic hormones. Adrenocorticotropic hormone, ACTH, TSH, thyroid stimulating hormone, luteinizing hormone, LH, and follicular stimulating hormone, FSH. LH and FSH have an opposite relationship to estrogen and progesterone, which when LH and FSH are at the highest, it means that the lady is just about to menstruate. When the estrogen and progesterone are at the highest, it means that the lady is just about to ovulate. And there's that 14-day relationship, therefore a 28-day cycle, correct? Posterior pituitary, we've already talked about this. Vasopressin is important because its name is anti-diuretic hormone. There are defects in ADH or vasopressin, and these defects occur in a 3rd type of diabetes, known as diabetes insipidus. Very good. Diabetes insipidus is a condition where there's a defect in the anti-diuretic hormone. In that situation, people just keep passing urine. Again, a little on the pathophysiology, basically the physiology. Know about the adrenal gland, know about the adrenal medulla and the adrenal cortex, right? It's the cortex that secretes the stuff that we're going to talk about, or we have talked about. All those steroids, the corticosteroids, the cortisol, etc. is manufactured by the cortex. What does the medulla secrete? The adrenal medulla secretes what? Adrenaline. That's the simplest question ever asked of you, right? Adrenal medulla, that's why it's called adrenaline, because it's secreted by the medulla. Important because now you see the relationship between the two in your clinical practice as well. 3 zones, zona glomerulosa, fasciculata, and reticularis, and they're all responsible for secretion of number 1, cortisol, that's the glucocorticoids. Number 2, aldosterone, which falls under what category? Mineralocorticoids. And number 3, sex hormones. So androgens and estrogen, right? All secreted by the zona glomerulosa and fasciculata and reticularis, which is a part of the cortex. You can see this block here, the histology that you see of this block is actually from right here, this area. It's still the cortex, not the medulla. Mineralocorticoids do what? Sodium retention. All right, that's important because sodium is retained, therefore water is retained. If sodium is excreted, then water follows through, right? The solvent always follows the solute. Glucocorticoids, cortisol, and that alludes to corticosteroids that people take and your patients will be on. And adrenal androgens, estrogens, and progestins. Dehydroepiandrosterone is important because that's what also converts into testosterone. So please remember that testosterone basically is produced in a way, so to speak, from estrogen. That's what. And of course, estrogens, which are estradiol, estriol, etc. You don't have to memorize any of these names. And the other 2 hormones that we're aware of. Know the functions of glucocorticoids, what they do in physiological roles and what they do in pharmacological roles. This, what you see here, is basically a physiological role of glucocorticoids on carbohydrate metabolism. They induce enzymes involved in gluconeogenesis. What is gluconeogenesis? If you're ever faced with that question, break the word up. Gluconeogenesis. Creation of new glucose from amino acids and fats. All right? I've said this to you before, and we'll talk about diabetes shortly, but remember that diabetes initially, many, many years ago, was thought to be a defect in the level of sugars. My sugar intake is high, C6H12O6 or C12H22O12, a large polysaccharide. Because my sugar intake is high, I'll end up with diabetes. Not anymore. The thought is diabetes occurs. Why? Because of increased calorific intake. Whatever it may be, proteins, fats, sugars, starch, etc. Because it will convert the body's fat stores, it will convert the body's amino acids, proteins, muscle mass into sugar. That's why when you see a diabetic for the first time, what is the typical description of a diabetic patient when they're diagnosed with diabetes in the primary care office? They're usually obese, right? They're usually obese, they're overweight, they have large girth, abdominal circumference, their BMI is very high. But what happens to an end-stage diabetic, somebody who's in their last stage of diseases? They're usually emaciated. There's skin and bones. Why? What has happened to all the fat and all the muscle mass that they had? It's all converted into sugar, gluconeogenesis. And so they have high levels of blood sugar, which they should not have, but no fat, no muscle, etc., etc. So that's typically what happens. Glucocorticoids do something very similar. Glucocorticoids also have an anti-insulin effect. So if ever in your practice or in the future or in your boards, you're asked, are glucocorticoid treatment chronic long-term therapy safe for diabetics? It is not. You have to up their medication or increase their insulin dosage because of the fact that they're on chronic steroids. Which patients could be on chronic steroid therapy? Could an asthmatic patient of yours be on chronic steroid therapy? Absolutely. How about somebody with psoriasis? Absolutely. How about with somebody who has a chronic inflammatory disorder, inflammatory bowel disease, for example, etc., etc. And you're stuck between a rock and a hard place because increased corticosteroids may cause increased chance of perforation of the bowel as well. Effects on protein metabolism. Remember, it stimulates the breakdown of protein. So steroids do this. They break down proteins. So when somebody has increased protein metabolism, it causes the effect that we typically see in patients. Now, this may be overturned by somebody who is exogenously taking a lot of steroids to build muscle mass. There's a difference here. That is not just a pharmacological effect, but that is increased muscle deposition, because increased steroids, when they're taken in, have to be taken with an increased intake of proteins. If there's no intake of excessive proteins and yet somebody's pumping themselves with testosterone or with androgens or with the muscle mass enhancing steroids, there will be a fall in the protein buildup. It has to be accompanied by increased protein intake. Increased fat metabolism, stimulate lipolysis. Again, if you get that word, breakdown of fat. Chronic high concentrations cause redistribution of fat. So fat goes from where it should be in the belly, in the gluteal region, on the shoulders, in the neck, in the face. It gets redistributed and ends up with a patient who manifests such. They have a pot belly, they have a face which looks round like a moon, and they end up with a lot of fat behind their neck called a buffalo hump. What is this condition known as? All of you should know this. It is called Cushing's. Cushing's syndrome. What is the difference between Cushing's syndrome and Cushing's disease? The syndrome occurs because of exogenously given corticosteroids. The disease occurs because of an inherent defect in the adrenal gland. All right? Now, this could be an inherent defect in a secondary ectopic part of the adrenal gland, which is still secreting cortisol. So remember Cushing's disease. Don't forget that diagram. You have that in your notes where it shows a person with a flat, moon-like faces, but dry skin and redistribution of fat. So potato on toothpicks, right? It's central obesity, thin arms and legs, thin limbs. Why the thin limbs? Because fat and muscle has been redistributed. It's gone central. What about the cardiovascular system? Remember, we're talking about glucocorticoids. Take a step back and think, what do steroids do to the cardiovascular system? Well, initially they cause an increased capillary permeability, and therefore patients who may be on steroids early may show some signs of pooling of fluid. So they may have swelling of their feet, edema, swelling around their eyes, periorbital edema. Okay, initially. They decrease the ability of blood vessels to constrict. This is initial. At high concentrations, rather 10 milligrams of dexamethasone given to a patient will cause what? When do I give 10 milligrams, which is by the way a high, heavy dose, as an injectable to a patient? When they're rolled into ER in a state of shock. If they're in a state of shock. Doesn't matter what caused the shock. It could be an electrical current, it could be hypovolemic, it could be blood loss, it could be injury or a wound. Steroids given at high doses will do what? They'll constrict the blood vessels, they'll make the heart beat faster, and they'll cause an increased stimulation of cardiovascular activity. Bring that blood pressure back. So anybody who's on steroid therapy, long-term or a high dose of steroid, what is your concern? The epinephrine that you may give along with your lidocaine may have certain effects that you may not want. The blood pressure may shoot through the roof. Skeletal muscle, we already talked about gluconeogenesis, loss of protein, conversion into glucose. Know that term, it's important. CNS, if there's not enough cortisol in the body, the individual goes into a depressive state, which means there's lethargy, there's a loss of interest in their surroundings, and they may go into depression. There's a second part to it, which is with very high doses of steroids, and what happens there? The opposite happens. They go into psychosis. What is the difference between depression and psychosis? Depression is a mood disorder. Psychosis is a thought disorder. It's a thinking disorder, right? Delusions, illusions, hallucinations, psychoses. Depression, sadness, suicidal ideation, right? There's a difference. If you're ever confused here and you want to know what happens with high doses of steroids, think of roid rage. What happens with roid rage? It's a psychotic effect. It's the reaction of somebody is much more, exponentially more than what would be expected. That's why it's called roid rage. Stress during anxiety, exercise, trauma, infections and surgery, which is your area of interest, glucocorticoid, cortisol secretion is increased. You know that. Cortisol is increased during stress, right? That's important. And if that happens, remember this could be a white coat syndrome where a patient already has high levels of cortisol, therefore high levels of adrenal medulla secretions as well, such as adrenaline, epinephrine. On top of that, we're giving adrenaline or epinephrine, which can cause delirious effects. I know this keeps popping up whether we do asthma or we do steroids or we do pain medications. This is important for you to know because you should know that there is a cyclooxygenase pathway for inflammation, which causes inflammation of arthritis or pain or mastitis or psoriasis or eczema or anything else. And then there's the lipoxygenase pathway on your right, LOX, which causes the inflammation we typically see in asthma, right, where there's bronchoconstriction. All of this is initiated with the release of arachidonic acid. Arachidonic acid is released, why? Because of the activation of an enzyme called phospholipase A2. So even though the left pathway, the COX pathway, creates all the prostaglandins which are causing inflammation, and the LOX pathway, the lipoxygenase pathway, is creating all the leukotrienes which are causing that inflammation. What is the drug of choice for arthritis and psoriasis and mastitis? And what is the drug of choice for asthma and sometimes COPD? Yes. Corticosteroids. Why? Take a look at what they do. Corticosteroids right up here on the top, they inhibit phospholipase A2. Okay? So you stop that cascade from happening right off the top. Off the top of your heads, take a look at these PGAs and TXAs and PGGs and PGF and PG. Which one of these prostaglandins is gastroprotective? PGE. PGE1 and PGE2. Remember, this is the one with the halo around its head. This is the good prostaglandin. And so when we inhibit cyclooxygenase by giving drugs such as Advil and Motrin and aspirin and diclofenac, Voveran and all of those drugs, you inhibit all these prostaglandins. In that process, you end up inhibiting PGE as well. Gastroprotective. Now you've inhibited the gastroprotective cyclooxygenase enzyme or prostaglandin. What's going to happen? You're going to expose the patient to a gastric or a peptic ulcer. Correct? And therefore, we pick and choose drugs which are called COX-2 inhibitors, selective COX-2 inhibitors, because COX-2 enzyme inhibits all these bad prostaglandins, but it spares PGE. And therefore the patient still gets pain relief, gets relief from inflammation, but does not get peptic ulceration. There's a second part to this slide. Do not forget these guys sitting by themselves in the center. TXA2, TXB2. What does TX stand for? Thromboxane. What is thromboxane responsible for? Platelet aggregation. By inhibiting cyclooxygenase with aspirin or ibuprofen, Advil, Motrin, or with naproxen, Aleve, you inhibit everything. By inhibiting everything, you also inhibit thromboxane. If you're inhibiting thromboxane, platelet aggregation does not occur, which means bleeding occurs. So the flip happens. Oh, here's the diagram I spoke of about Cushing's syndrome or Cushing's disease. Take a look at all of these events, the signs that you see here. They are important because any or all of them, and again, you don't have to memorize them, just think of it as the diagram itself. You can see this. What's the problem with using steroids? They depress or suppress immunity. If they're used locally, they suppress local immunity. When are steroids used locally or topically? Skin disorders, of course, but important for you in the oral cavity. When patients are being given inhalers, which are steroid inhalers, there could be a deposition of that active ingredient at the back of the throat. Because of that, local immunity is suppressed, because of which somebody could end up with oral candidiasis, such as what you see on the screen. When can we not give steroids? When there's a chronic infection, such as tuberculosis, when there's increase in intraocular pressure, when there are infections such as fungal, viral, or parasitic, herpes, herpes simplex, herpes zoster. If there's a peptic ulcer disease, why? Look here. What are you inhibiting? You're inhibiting, with using steroids, you're inhibiting this entire process. And by inhibiting arachidonic acid, you are therefore inhibiting the gastroprotective PGE as well. Osteoporosis, again, back to that diagram, you can see what it does to bones. Because Dr. Gupta may talk about that. Psychosis we talked about, and uncontrolled diabetes. What is Addison's disease? Not enough cortisol in the body. Addison's disease occurs because there's not enough steroids in the body. So what's the treatment of Addison's disease? Easiest question ever asked. Steroid replacement therapy, right? Just replace the steroids. So typically, you see your patient sitting in your chair with 5 milligrams of prednisone given twice a day for 10 years, or 10 milligrams of betamethasone given once a day for 8 years or 6 years. Long-term steroid therapy, think Cushing's. I'm sorry, my apologies. Think Addison's, because where Cushing's has excessive steroids, Addison's has inadequate steroid therapy. It's called primary adrenal cortical insufficiency. That's the other name of Addison's. Primary, because there could be a secondary adrenal cortical insufficiency, secondary to a cause. Somebody was being treated with anti-steroid medication. Or there could be adrenal hyperplasia in certain situations. What else do we use it for? Anti-inflammatory, you know that already. Cancer, chemotherapy, immunosuppression. Any person who's in shock or in hypotension, we use steroids. This brownish discoloration in the buccal mucosa is inherent. It is a classical sign of Addison's disease. So typical hyperpigmentation occurs. The reason is the primary stem hormone is a melanocyte secreting hormone, and that's why when there's not enough steroids in the body, there's an increase in melanocyte deposition of pigmentation inside the oral cavity, the squamous epithelium. Switching gears to thyroid disease, hypo and hyperthyroidism. Know this chart. Paste it in front of you. Know all these steps, because any drug that I ask you will fall into one or two of these categories. I like this because it has some of the drugs mentioned as well. I think there's another slide coming up which has the drugs. So, which element is essential for production of T3 and T4? Iodine, right? Without iodine, you cannot get normal thyroxine. Thyroxine is divided into T3 and T4, right? Which is the active thyroid hormone? T3. Which is produced in more quantity? T4. What happens once it's produced and secreted by the body? T4 is converted into T3. Okay. Know these names. Organification is when the thyroglobulin molecule comes together with iodine in the presence of an enzyme called thyroid peroxidase, and coupling is when MIT and DIT come together. MIT stands for monoiodothyronine and DIT stands for diiodothyronine. One has one molecule of iodine, the other one has two molecules of iodine. When one molecule and two molecules combine, they produce T3, right? 1 plus 2 is 3. And when two molecules of diiodothyronine combine, 2 plus 2 becomes 4. So it produces T4. That's how T3 and T4 are produced in the body. As you can see in this diagram, that thicker arrow means that T4 is produced in much higher quantities than T3. However, T4 peripherally converts into T3, and T3 is what we essentially need, patients need. I like this slide because it talks a little about the kind of diseases that patients may have. Normal, remember the axes, don't forget that. TRH, thyrotropin releasing hormone. TSH, thyroxine stimulating hormone, and T3, T4, which are L-troxin or levothyroxine, right? And remember this feedback mechanism. Graves' disease is the most common form of hyperthyroidism, which means that there is not enough TRH, not enough TSH, because the feedback loop is saying, don't produce anymore. There's enough already in the body. However, there's increase in thyroxine, T3 and T4. Hashimoto's thyroiditis is a situation where there's not enough. So there's no feedback, and therefore TRH from the hypothalamus and TSH from the anterior pituitary are constantly secreting, stimulating the thyroid gland. But what's the problem with the thyroid gland here? That's where the defect is. Autoimmune defect. When does Hashimoto's thyroiditis occur? Most commonly, it has been shown to occur postpartum. Women, after delivering their baby, have been known to suffer from this. What are the three types of hypothyroidism that you're aware of? Primary, secondary, tertiary. Where is tertiary? Up at the highest level, the hypothalamus. Where is secondary? At the anterior pituitary. Where is primary? At the thyroid gland. Do not forget that. Some of the drug interactions, very quickly. Cholestyramine, this is a lipid-lowering agent. So that's one area where there could be a decrease in the thyroid production. Antacids, why? Because remember that antacids are chelating. They chelate. They grab like a crab and don't let go. So chelating agents, important. Proton pump inhibitors, lansoprazole. This is important because Prevacid, omeprazole, certain other PPIs, because these drugs decrease the absorption of thyroxine. How do you give thyroxine to a patient? Orally. When do you give thyroxine to a patient? First thing in the morning, empty stomach. And then you ask the patient ideally not to consume food for up to 2 hours. That's when it's absorbed the best. Okay, not always possible, but that's when you do it. Or 2 hours after a meal. Rifampicin and phenytoin are also drugs that interact. What is rifampicin? Antibiotic used for tuberculosis. Good, tuberculosis. What is phenytoin? The other name of phenytoin?
Dilantin.
Dilantin, very good, dilantin. Chief side effect of phenytoin / dilantin?
Nice day.
Severe gingival hyperplasia. Not just hypertrophy, but hyperplasia. Gingival hyperplasia, phenytoin. All right. Which other drug causes gingival overgrowth? Hypertrophy. Antihypertensive, calcium channel blockers. Hyperthyroidism, which is the opposite of what we were discussing earlier. Graves' disease. Here are some names. Please know this. Toxic multinodular goiter called Plummer's disease. Causes increased secretion. Toxic adenoma. As I said before, an adenoma is the most common mass that you will come across as a clinician. Right? The ladies who complain of a lump in the breast, when we do an FNAC, fine needle aspiration cytology, you take a biopsy from the breast. What's the most common form of breast lump? It's a fibroadenoma. All right? Some of the most common causes of endometrial in the uterus growths are endometrial adenomas. Okay, so adenoma is a very common type of a tumor. Does an adenoma cause an increase in the function of that gland? Yes, it does. So will a patient who has a toxic adenoma eventually produce more thyroid hormone? Yes, they will. You've probably seen this or heard it from people, right? They say that I had nodules in my thyroid gland. That is a toxic adenoma. That nodule is causing. Sometimes you just remove the nodule, sometimes you do a thyroidectomy. And subacute thyroiditis or Hashimoto's thyroiditis, etc. Classical postpartum. Thyrotoxicosis has what symptoms? The opposite of hypo. In hypo, everything slows down. In hyper, everything quickens up. Excessive. A hypothyroid patient always says, I'm freezing. I'm feeling very cold. This room is very cold. A hyperthyroidism patient says, I'm sweating because it's so hot. They have increased BMR, basal metabolic rate. Because of the increased sympathetic activity, your hyperthyroid patient will always have a higher blood pressure and pulse rate. They will also have hyperalgesia. Hyperalgesia stands for increased pain. Eyes sometimes protrude. What's that known as? Exophthalmos. They will have anxiety. If you have a patient with diagnosed hyperthyroidism, please be very careful with epinephrine. I haven't gone into the details of drugs, but here are the drugs that you have to know about. Know all the mechanisms of action. Take that little organification coupling diagram and insert these drugs there. That's how you learn between now and next Monday about what they do. Thioamines, PTU, propylthiouracil, and methimazole are two important drugs here. Thiocyanate, we don't use this much, but it's a detoxification product of almost potassium cyanide. Iodine is of two types. One is just potassium iodide. Why? Because iodine is responsible for T3, T4 production. Sometimes just supplementing a patient's iodine helps in getting normalcy back in patients. However, if that doesn't occur and the patient's thyroid gland is doing way more than it should, we use a mechanism called radioablation. You ablate means to destroy. And we destroy parenchymal tissue by radioablation. What radioactive ingredient do you use? Radioactive iodine, I-131. Why do you use iodine? It has a predilection, it has a priority to go where? To the thyroid gland. doesn't go to other tissues, goes to the thyroid gland, and that's why it goes and radio destroys or radio ablates. Why beta blockers? Why do I have beta blockers on this list? For hyperthyroidism.
Slow down.
What did we say in the previous slide? What did we say increases? Sympathetic activity. The patient's blood pressure is through the roof, their anxiety level is through the roof, their pulse rate is high, their heart is pounding onto their chest. What do you want to do to all of that? You want to decrease that sympathetic overactivity. How do you do that? By giving a beta blocker. You settle the patient down. Beta blockers, even though they're used for hypertension, are some of the most popular drugs for anxiety and paranoia and panic attacks today. This is the diagram I was talking about, referring to. You can see all of the drugs and where they act: iodides, thioamines, thiocyanates, and propylthiouracil. Note these mechanisms. Iodine 131 right here. Please note these mechanisms. Diabetes, two types, type 1, type 2. Basically a defect either in the pancreatic secretion, right, of insulin. Where's insulin secreted from? Beta cells. What other cells are there in the pancreas? Alpha. And what do alpha cells? Delta and F. What do alpha cells secrete? Glucagon. Glucagon and insulin have an opposite effect. They balance each other off. Which means insulin takes the sugar that was present in our breakfast and now is in our blood and throws it into the cells for use and for energy. Glucagon takes the stored sugar, stored in the form of glycogen where? In the liver, and throws it back into the blood. So that's the relationship that they have. Know this mechanism. It's a simple diagram, but know that glucose enters the cell. Once it's in the cell, it undergoes phosphorylation, ATP, which causes not opening but closing of which channels? Potassium. Remember closing and remember potassium. Important. Potassium channels close. Closing of the potassium channel causes calcium to rush in either from outside the cell or in this area of storage, a sponge called the sarcoplasmic reticulum. And it causes that release of calcium. Calcium, as soon as it's released, causes insulin granules to move towards the cell surface, inner side of the cell surface, and be released. What do you call a gland that releases its secretions directly into the bloodstream? An endocrine gland. What do you call a gland that releases its secretion through a duct? Exocrine gland. Please name me an exocrine gland that is important for you. All the salivary glands that you know of, the parotid, the submandibular, sublingular, are exocrine glands. Right? What is the pancreas? Is it an endocrine organ or an exocrine organ? Both. Insulin and glucagon are endocrine. Pancreatic enzymes, lipase, amylase, etc. are exocrine. Complications of diabetes. Do not forget the three. I know that there are some clicker questions that I've thrown at you in the past. Retinopathy, nephropathy, neuropathy. All right, important, because all of them are the blood vessels and arteries that are impacted. Atherosclerosis increases. Muscle and tissue wasting, we talked about that. What kind of a hormone is insulin? Is it an anabolic hormone or a catabolic hormone? Insulin is? It's anabolic, right? Insulin takes sugar and it stores it. It takes it out of the blood and stores it. So it causes anabolism. It's known for that. However, if there's increased breakdown of proteins, fats, and sugars, there could occur ketoacidosis. So that's important. Ulceration, don't forget the diabetic foot. Type 1 diabetes. Off the top of your head, drug of choice for type 1 diabetes? Insulin, insulin, and only insulin. That's all we can give to the patient. All right. So it's kind of a simplistic answer, but it's a complicated management modality. What's the most common cause of type 1 diabetes? It is autoimmune. While the baby is in the fetus, the baby's in the fetus, I'm sorry. While the baby is in the uterus, that would be a funny kind of a term. But when the baby is in the uterus, then at that time, she's receiving nourishment from her mom, right? From the placental blood vessels. However, once she comes out, there could be a loss of activity of her pancreas. There's complete destruction of pancreatic beta cells, no circulating insulin. There's a starvation-like response to the body. Babies born Diabetic usually are what? Are they emaciated and low for gestational age, or are they bigger? They're bigger babies, all right? They're bigger babies initially. However, they soon start losing weight and they have no insulin activity. Insulin is anabolic. Insulin should have taken all that breast milk that the baby consumed. What's the name of the first suckle that the baby takes? What do you call that milk? Colostrum. Very good. C-O-L-U-S-T-R-U-M. Colostrum. Colostrum is the first. It is the highest in immunoglobulins. It's the highest in antibodies, and it's the highest in protein. So babies need that colostrum. It's very, very important. Good. Glycogenolysis and gluconeogenesis occur. Know these words. Know the difference between the two words, right? Glycogenolysis. Look at the word before you answer in an exam. Glycogenolysis. Breakdown of glycogen. Gluconeogenesis. Creation of new glucose. There's a difference between the two. They're both, by the way, if I were to ask you, which of the following processes end with increased glucose production? Your answer is both. Glycogenolysis also increases glucose. Why? Because it's breaking down glycogen. Gluconeogenesis also increases glucose because it's creating new glucose from fats and proteins. So don't let that confuse you. But they are separate mechanisms. Muscle breakdown, we talked about that. Adipose tissue, what causes, know this please, what causes ketoacidosis in an uncontrolled type 1 diabetic? It is the acetoestates which form ketone bodies. Ketone bodies are breakdown products of fat. Normally fat should just break down into simple lipids and be excreted or go through the bile and be excreted in the stercobilirubin. But in this situation, diabetics, it forms ketone bodies, acetoacetate, which results in metabolic ketoacidosis. Here are some of the insulin preparations that you should know of. Rapid acting, ultra short, aspart. Short acting, regular, intermediate acting, NPH. If I were to ask you, in our bodies, in the normal individual, what is insulin associated with? Which element is insulin secreted with? Your answer is zinc. Always zinc. Insulin naturally secreted in the body comes hand in hand with zinc. And therefore some of the preparations are called insulin zinc. And here are the pre-mixed combinations that you'll see. What's the adverse effect of insulin therapy? The first thing that should come to your mind ever is hypoglycemia, because that's what its job is. It's supposed to decrease, and you know everything about hypoglycemia. What are the symptoms of hypoglycemia? Take a look at all the sympathetic activity that you're aware of. That's what happens. Pulse rate gets high, they start sweating, they have a dry mouth, they start feeling anxious, sometimes belligerent, sometimes in a state of altered orientation. Type 2 diabetes could be because of a defect in the beta cells, right? Not enough insulin. Number 2, and more importantly, it could be because of tissue insensitivity. The tissues there's insulin in the body. Insulin is supposed to take the glucose from our meals, from our stomach, jejunum, ileum, duodenum, and stomach, and push it into the blood vessels. Why? Because of insulin receptors. Those insulin receptors do not recognize the insulin that we are secreting. So when they do not recognize insulin, the sugar remains where? In the blood. Where should it have gone? To all the cells and the tissues and the muscles. Here are all the drugs that you need to know. You need to know these mechanisms. Again, if I look at this slide, 1, 2, 3, 4, 5, 6, 7, 8. I have 8 drug groups here, 8 categories. You can expect 6 questions out of this slide. Okay? The reason I say this is because this is basic pharmacology. You have to know the mechanism of action of alpha-glucosidase inhibitors. Know that alpha-glucosidase is an enzyme that breaks down polysaccharides into monosaccharides. Alpha-glucosidase, if you inhibit the enzyme, you have lots of polysaccharides. What happens to polysaccharides in the stomach? They do not get absorbed. If they don't get absorbed, they stay in the stomach. And that's how you can reproduce. DPP-4 inhibitors, there's some genetic mechanisms involved. Know those mechanisms. PPAR alpha, remember that peroxisome enzyme, etc. There are certain injected drugs. One example is exenatide. Exenatide is getting very popular. It's available in the market as Byetta, by B-Y-E-T-T-A. Know some of these drugs. The 2 most important drugs in this category are the sulfonylureas and bigonides. They're always drugs that are used. Metformin is the #1 anti-diabetic drug all over the world. Not just the United States, all over the world. Metformin is used most commonly. So I haven't gone into details of mechanisms because I expect you to be able to do that, but know these mechanisms. Pain, moving on, this is the last part, I'll give me about 5 minutes. There are peripherally acting analgesics, those that act in the periphery, NSAIDs, COX-2 inhibitors. These are drugs that you use in case of an actual physical injury/inflammation because they are anti-inflammatory. They are analgesics, but they also have anti-inflammatory action. That's why you use NSAIDs. Centrally acting analgesics are used when a patient has pain, but there's no inflammation involved. And in such a situation, Tylenol or Acetaminophen is as good a drug for you as a dentist as is codeine. All right? The combination of both, of course, is good. You've heard of Tylenol 3, right? But Tylenol alone is a good trial drug at the beginning. What other centrally acting analgesics are you aware of? Do not forget the opioids and tramadol. Tramadol is separate from regular opioids because most opioids are plant-derived, right, from the poppy plant. Tramadol is synthetic. It's a synthetic opioid. They act in the thalamic region of the brain, which is the pain center. Then there are analgesic adjuvants. Do not forget these. Drugs such as amitriptyline. Somebody wants to tell me what amitriptyline is? Available in the market as Elavil, E-L-A-V-I-L. Tricyclic antidepressant, right? Good, very good, tricyclic antidepressant. Carbamazepine, available in the market as Tegretol. It's an anti-epileptic. It's used for convulsions and seizure disorders, but used here for pain management, all right? Caffeine, of course, we've already. If I were to add a drug called Neurontin on this, what is Neurontin? This is for your boards, not just for this exam. So never forget this. Neurontin is gabapentin, and any drug which has GABA in it is always a drug that acts at GABA receptors, right? So you've heard of Lyrica? Lyrica, it's on the market, right? It's called tiagabalin. So these are some of the commonly used drugs for pain management. And of course, there are thermoregulatory protein channels. And if you want to block those channels, you use drugs such as capsaicin. I said this in class. They work through a mechanism of counter-irritation. They irritate that part of the oral cavity, thereby taking away. What if your patient is in excruciating pain and there's nothing else that you can do with medications? Come on, Dr. Victor. What will happen then? What's the best thing to do in such a situation? A nerve block. A nerve block works wonders. If a patient is in such excruciating pain that you don't want to initiate them on high doses of fentanyl or other opioids, remember you always have the option. Which physicians don't, by the way. You have that expertise to actually know where nerves are and block that nerve for that patient's acute pain, not chronic pain. Know the step ladder, the pain step ladder. I was preparing this last night. My son walked by the sofa I was sitting in my living room, and he said, "Dad, did you make this light?" And I said, "No, I took it off the WHO website." He said, "Yeah, because all those angles are all wrong." So he was kind of, and when I noticed, I said, "Yes, that doesn't look nice at all." But we're here to learn, right? We're not here for the aesthetics of it all. But remember, you start with some simple drugs like Tylenol, Acetaminophen. You can add an adjunct to it. Caffeine is a good example. If that doesn't work, you go to the next level, which is low impact opioids such as codeine, right? Or oxycodone, so Vicodin, starting with just the regular Vicodin. If that doesn't work, you go to the third level. What drug sits on top of that pain pyramid? Fentanyl, also known as Duragesic. That's right there on top. Fentanyl is a synthetic opioid. All right, so know this. There is a drug which has come in, which is way more powerful, 100 times more than fentanyl. It's called sufentanil. S-U-F-E-N-T-N-I-L. Sufentanil. Non-opioid analgesics, we've been talking about this already. Acetaminophen, NSAIDs, we've mentioned this again. If you take a drug such as aspirin, and if you take a drug such as ibuprofen, and if you take a drug such as acetaminophen, if I ask you, which of the three drugs have the best anti-pyretic activity? Aspirin, ibuprofen, and acetaminophen. What's your answer? Anti-pyretic, which means something that brings fever down. What's your answer? Acetaminophen. Tylenol has the best anti-pyretic activity. If I ask you, you have three drugs, aspirin, ibuprofen, and acetaminophen. Which of the three drugs has the least anti-inflammatory activity? What's your answer? Least anti-inflammatory.
Acetaminophen.
It's still acetaminophen. Okay? It has least anti-inflammatory but best anti-pyrexic. Okay? If I were to ask you which of the following have the best anti-inflammatory activity, ibuprofen, acetaminophen, and codeine. Which has the best anti-inflammatory activity? Ibuprofen. That's why it's called an NSAID. All NSAIDs are nonsense. If I were to throw a curveball into that and added a steroid, now what's your answer choice? The steroid is always done. Steroids have the best anti-inflammatory effects. NSAIDs second. Acetaminophen and centrally acting codeine lowest. Anti-inflammatory. Analgesia, acetaminophen sits right up there with codeine. Low dose opioids. All right. Some drug interactions that are important for you. Do not forget the alcohol and acetaminophen drug interaction. What important metabolic pathway should you remember in this situation? That glutathione pathway. Do not forget that. That's the pathway which is usually taken by acetaminophen when it breaks down. Glutathione pathway, which is a conjugatory pathway, causes inactive metabolites to form. However, you add alcohol to that level, alcohol now saturates that glutathione pathway, that conjugatory pathway, because the enzyme alcohol dehydrogenase. When it does that, acetaminophen now has to follow a secondary pathway which results in the production of a highly toxic substance called NAPQ1. And NAPQ1 is so toxic that it results in hepatic breakdown, liver cell breakdown, thus the liver toxicity. What is the most important cause of liver transplants in the United States? Is it A, alcohol? Is it B, marijuana? Is it C, Tylenol? Acetaminophen is the major cause of acetaminophen alcohol syndrome, hepatotoxic drugs, and warfarin high doses. What's the mechanism of action of warfarin?
C-vitamin blocks. Oh, it's a vitamin K antagonist.
It's an antagonist of something. Vitamin K. It's a vitamin K antagonist in the liver, so please remember that's the mechanism of warfarin. We've done this diagram before. I just wanted to put NSAIDs into it. As you can see, we've lost the lipoxygenase pathway now because this is just pain control. Where corticosteroids act at that upper part where arachidonic acid is being produced, NSAIDs act lower than that, inhibit cytooxygenase. Here's some brand names. As I said earlier, we'll never ask you match the following, match Voltaren to A, naproxen, B, ibuprofen, 3 ASA. No, we won't ask you that. But sometimes these are important names. Aleve, for example, you can associate with, know that it's naproxen. We will add brand names just for those people who identify more with the brand name. You know Tylenol, but as a pharmacologist, I have to rely on you knowing acetaminophen. It's important for you to know that. Some drug interactions. This is a blanket rule, and you can pen that down, you can scribble it in your notes, where remember all NSAIDs interact with all antihypertensives if given for more than 7 to 10 days. Before that, it's not a big deal. But if your patient is receiving an NSAIDs through you, and if you have to give it for more than 7 to 10 days, and the patient is on an antihypertensive, you have to make sure that you either adjust or you inform the physician, the primary care, to adjust. There's only one group of antihypertensives that are not impacted by NSAID use. Does anybody know which one? It's obviously not here, so you can pick and choose.
Calcium channel.
Calcium channel blockers. Do not forget that. Calcium channel blockers are the only NSAIDs, otherwise it's a blanket rule. Other than that, calcium channel blockers are the only NSAIDs that can be given for more than 7 to 10 days without their anti-hypertensive effect being lost when NSAIDs are given for more than 7 to 10 days. Now, you may not prescribe NSAIDs for more than 7 days as a dentist, but remember the patient may already be on NSAIDs because they have an Crohn's disease or other inflammatory diseases. COX-2 inhibitors, as we said, you remember that PGE, we said that COX-2 lets the good prostaglandin be, it lets it be, and only inhibits the bad prostaglandins. What's the problem with COX-2 inhibition? If you only inhibit COX-2, it sometimes impacts the cascade of events and pushes that cascade or that cycle towards TXA2 and TXB2. And you said that thromboxane was responsible for platelet aggregation. So on one side it inhibits all the inflammatory prostaglandins. On the other side, it causes increased. It's not inhibiting thromboxane. It's increasing thromboxane's activity, which causes even more platelet aggregation. Therefore, what can celecoxib do to a patient? It can result in a stroke or an MI, right? Cardiovascular events. Opioids, very quickly. I'm almost done, Dr. Gupta. Give me a couple of minutes. Which is the most commonly available combination for opioids in the United States?
Codeine.
Vicodin is the most common. Hydrocodone and acetaminophen, this one in red, 63%, are the maximum number of prescriptions that are given. Codeine plus acetaminophen is also very, very popular, but not as popular as Vicodin. Vicodin is very popular. And here's why more and more dentists are turning towards using only acetaminophen. If they have to go to the next level, they don't give codeine, they go straight to hydrocodone, which is Vicodin. What's the max? I don't think I have it here. What's the max? What's the total amount? The three types of Vicodin: Vicodin ES, and Vicodin HS. How much acetaminophen in all three?
325.
300 milligrams. Please know that 300 milligrams, right? Even though the hydrocodone part goes from 5 to 7.5 to 10, it increases in its dosage, but acetaminophen remains at 300. Here are some strong opioids. Know these off the top of your head. MS-Contin, which is morphine, meperidine, methadone, fentanyl. What's the other use of methadone? It's a drug that, what is methadone used for? For opioid-dependent patients, right? It itself is an opioid, but it's used, you've heard of methadone clinics, right? You all have heard of methadone clinics. That's typically what we do. We give the patient methadone to wean them off the other drug that they are dependent on. Weak opioids are drugs such as codeine, oxycodone, hydrocodone, and pentazocine-tolerant. Know about these drugs. There are notes. Every slide has just one page, but know about that. Morphine acts where? Those opioid receptors, the ones that you should be aware of, are mu and kappa. What is the antagonist at mu receptors? Naloxone. What is the drug that we give to a patient who is in opioid toxicity? Naloxone. Have you heard of Narcan? Narcan, available in the United States, and now every household which has an opioid user should have Narcan in their house. What causes the dependence? Which receptor causes dependency to morphine? The mu receptor. Which receptor is responsible for the opioid high or the feeling of euphoria? The mu receptor. Which receptor is responsible for respiratory depression? The mu receptor. That's how important the mu receptor is. I think that's my last slide. That's a pain pyramid. We've already talked about this. As you can see, fentanyl sits right at the top. At the moment, we are not exceeding 4,000 milligrams of acetaminophen per day. That's the maximum dose right now. However, by the time you guys graduate and are practicing, it will be 3,250. The FDA has already sent that update out. Why 3,250? Because every tablet of acetaminophen is going to be limited to 325 milligrams, which means that patients can take a maximum of 10 tablets. 3,250. What is the dose recommendation right now in a patient? Know this? In a patient who has liver toxicity? 2 grams. Today, 2 grams. 2,000 milligrams is the limit for liver toxicity. 4 grams right now, 4,000 milligrams is the limit for the use of acetaminophen. How long can you, as a dentist, give a patient opioids without enrolling into the prescription monitoring program in Michigan? 3 days. 3 days. How long can you give opioids to your patient? How long can your script be? 7 days. Does everybody get that difference? I'm glad you guys answered that correctly. So the maximum you can prescribe is 7 days. By all means, do once you're out of here. You can prescribe for 7 days. But if you're prescribing for more than 3, you have to enroll in the Michigan PMP, Prescription Monitoring Program. Why? To track the patient's history of use of opioids. Any questions that you may have? Expect how many questions, Dr. Gupta? 75, maybe 80? 75? 90? 100? How many? If you don't answer, I'll just keep going.
200.
120, let's do it.
Here's the thing, more the questions, better the chances that you do well.
1,000 questions.
Trust me.
That's not true.
We'll probably give 80 questions. It is an hour and a half exam, so somewhere between 75 and 80 should be. Do you guys, Dr. Gupta, you're looking at about 15 minutes? More or less?
No, I take a little longer.
Okay. Okay.
I mean, you can go on a break, but
okay.
you can go on a break.
Whatever. I won't interfere with your part, but I will tell the students. So if anybody wants a quick break, fine. This will be helpful for your exam. So thank you for your patience and good luck to all of you next Monday. I'll have an announcement out for the time of exams.
One.
One this morning and we have one at 1.
Okay, so I'm very happy that you all are here because the questions, things I'm going to discuss now, you will see them on the exam. This is my first ever review and I didn't know what else what other style should I use to do a review. So if you want to really achieve good score, then your friends, those who are resting or preparing for the next exam, then don't share the information you get here. Okay? Lucky you all. Let's start. But I'll leave you quickly, 20 minutes, right? So I'm going to ask some questions and if you want to come a little closer, it's up to you. Let's I really can't tell you the exact question, but we will focus on the exam questions. So what do you think is the cause of deficiency of vitamin D in small babies? You have to answer. Lack of sunlight in the small baby?
Not getting enough in their diet.
Not getting enough in the diet because mom's milk is lacking in enough vitamin D, right? So they have to get the supplements. And what do you think is the cause of vitamin D deficiency in elderly population? Elderly people, they walk less, they go outside less, and they get less sunlight, and especially in places like Michigan, where for 6 months we didn't have sunlight, right? What else? Yes, their lack of ability to walk, then they can get outdoors, but we always have to focus on what is the most likely cause of vitamin D deficiency, right? Their intestines are not functioning that well, their absorption is reduced, but the biggest factor is that they cannot go out. The sunlight, the skin is not forming enough now. What are the 3 forms of vitamin D? You know of them. You have to speak up. You can say wrong, doesn't matter.
25.
It's right in front, just say it. If I'll say them, it will be like I said the answers. Calcidiol, calcitriol, that is activated in the kidneys, and cholecalciferol. So what is the role of kidneys in calcium and phosphate metabolism?
Activates. They're pretty
Where is vitamin D activated?
in the skin.
In the kidneys. So calcitriol is causing the absorption of, vitamin D is causing the absorption of calcium in the intestine. And kidneys are causing the absorption of calcium in the kidneys and causing excretion of phosphate. Right? When is your exam?
Monday. A week.
So that's why you haven't read enough, I think. It's okay. And the recommended dose of vitamin D is 200 to 600. So you think somebody who drinks like 10 cups of milk can get vitamin D toxicity? Yes or no? No. 10 cups is okay. I have done that, so it doesn't matter. But our skin also has capacity to stop making vitamin D once enough is made, and you think prolonged sunbathing can cause vitamin D toxicity? It will stop making, right? Our skin is going to stop making. Then what else? You think consuming high amounts of vitamin D supplements can cause it?
Yes.
Okay. So let's go to, what do you understand by hyperphosphatemia? Hyperphosphatemia?
Well, if they consume a lot of vitamin D, they don't or do get toxins.
They can? Yeah. Somebody who eats a lot of vitamin D, then what will happen? Lots of calcium will be absorbed in the GI tract. And that can cause hypercalcemia. Hypercalcemia can cause symptoms, such as, we'll come to that later. So what form of vitamin D is responsible for formation of like mineralization of the bone?
Diet.
Is it cholecalciferol, calcidiol, calcitriol?
Cholecalcitriol.
The active form of vitamin D in the body is calcitriol. Calcitriol is formed in the kidneys. Calcitriol is responsible for mineralization in the bone. Cholecalciferol is either taken by mouth, then it goes to the liver. Liver converts it into an active form called calcidiol. Calcidiol is converted to calcitriol by the kidneys. That calcitriol is causing mineralization in the bone. All of us, we know that hyperparathyroidism causes hypercalcemia. The role of parathyroid hormone is to cause increased resorption of calcium from the bones. Parathyroid hormone is bringing out calcium from the bones, resulting in increased levels in the serum. So what do you think when there is hyperparathyroidism, what's going to occur in the body?
A weak bone.
The role of parathyroid hormone is
Increased calcium.
increase calcium in the blood by causing increased resorption from the bone. So if there is too much parathyroid hormone, what will happen?
Weak bones.
Weak bones. And how will it impact impact your patients? Yes, somebody said jaws, loosening of the teeth, gum diseases like periodontitis. What else? Difficulty in chewing. Too much partying over the weekend. Look at you.
More studying.
Studying? Okay. I can't tell you more than this. So you guys must read when you come for your exam. Okay. Let's go to that one. What's the outer part of the bone you see in the picture?
Cortex. Cortical bone.
Cortical. And where is the spongy part?
Inside.
Inside the bone. So there are two terms, osteoid and bone matrix. Which one you think is formed first?
Osteoid. Not bone matrix. No, the osteoid.
Decide on it quickly.
It's the osteoid that matures into the bone matrix.
So which one is formed first? Yeah? So this was taught in year 1, year 2, every year. Which one is formed first, osteoid or matrix? Just the guesses and then you will get the correct answer. So osteoid is formed first, then calcium and phosphate is laid down to form matrix. Take a look at the role of osteonectin. Osteonectin is responsible for binding calcium with collagen. That's important as well. What's hydroxyapatite? When osteoid is mixed with calcium and phosphate, it forms hydroxyapatite. Okay, you see osteocytes in the picture. What are osteocytes?
Cell. Trapped osteocytes.
Bone cells that are embedded in the matrix. From what cells form osteocytes?
Osteoblast.
Osteoblasts. Good. Anybody can tell me what are cytokines? Cytokines are inflammatory mediators. Yes, they are the substances that are released by immune cells and they have a role in formation of the bone. What is their primary role? What do you see in the picture? Are they responsible for formation of rank ligands or rank? Where do you see the arrow? Name some cytokines.
Prostaglandin.
You never bothered to look at the slides. It shows you. Name some more cytokines from the picture.
Prostaglandin. Interleukins.
Yes, interleukins.
Prostaglandins. PGT.
Prostaglandins are not cytokines.
Oh.
Then
Estrogens. Osteoprotectors.
Then tumor growth. Pardon me?
I had TNF.
Yes, TNF, tumor necrosis factor. Then these cytokines are responsible for formation of rank or rank ligands. Where is rank ligand?
Ligand.
On the osteoblasts. So cytokines are responsible for formation of rank ligands. Do they have a role in activation of osteoprotagrin?
They inhibit.
Osteoprotagrin is binding to rank ligands and not letting the rank ligands combine with rank. Rank is present on osteoclasts. Cytokines have nothing to do with osteoprotagrin. Okay. So which is the first phase in bone remodeling? Just take a look at the picture and say it. Activation. And which is the last phase?
Quiescence.
That's the time when bone is doing nothing. It's just waiting to go into the next cycle. So you've extracted a tooth in your patient. Which one do you think is the first step after day 1? Is it angiogenesis or new bone formation or bone growth?
Angiogenesis.
Angiogenesis is the first step in the first 1 to 2 weeks, and then the new bone formation starts, and finally there is bone growth resulting in bone reorganization in 4 months. That time is important because then you will know what's the stage your patient is at. You would want to check your patients, especially those who are on bisphosphonates. Okay? Any questions around that? No? Good? Let's go to the next presentation. I hope nobody is trying to record. So when you do an X-ray and you see that bone is radio opaque, what does it tell you? If the bone is radio opaque, what does it mean? Have you tried taking X-rays in the clinic? It's dense. If the bone is dense, it does not allow the X-ray radiations to pass through, and it looks white on the picture. If the bone is not dense, it's going to look radiolucent. You think there are diseases when bone can look extremely opaque? Can you say some? 1 or 2? Or conditions?
Osteopetrosis. Osteopetrosis.
Osteopetrosis, yes, and somebody who has excess growth hormone. They will have enlarged skull, enlarged jawbone, more opaque bones. So you have taken an X-ray and you see that the bone is radiolucent, the jawbone is radiolucent. What is your next step? You start doing your procedure, you don't want to bother, or you want to put the patient on bisphosphonates, or you want to call the specialist right away. What would you like to do?
Call a specialist.
Or you would like to ask a little few more questions regarding history, right? That's the one. Suppose there is a, you take an X-ray and you see, and you can see a missing tooth. You want to take the history. If the person or the child had trauma, or is that will tell you, the history is going to then tell you that whether the tooth is embedded or there was an injury, there was a fracture, right? And the person lost the tooth. So always focus on taking a good history. Which one do you think when patients are given medications, which is the most common side effect of medications? And we don't bother about it. Have you ever tried opening lexicon? Every drug, almost every drug says nausea, vomiting, diarrhea. Almost every drug, right? And we don't really bother about that. When do we bother? When it is excess gastritis, excess nausea and vomiting with a specific drug. Why do we bother? Because we prescribe painkillers to our patients, like NSAIDs. They cause gastritis. So which one of these drugs do you think can cause gastritis and GERD-like symptoms? Louder? Calcitonin. All drugs, they cause gastritis and nausea, vomiting, diarrhea, but the amount seen with bisphosphonates is extremely high. Let me show you here in the side effects. There. What's written at the top? Irritation and erosion with oral therapy. And it's important because sometimes your patient might have forgotten the instructions of the physician. The drug is given in the morning, and for 1 hour, patients should stay upright. Patients who are given bisphosphonates must stay upright for 1 hour to avoid this symptom. And I do want you to take a good look at all the side effects that are caused by various drugs. And when you go on to the side effects slide, take a look what will be seen in dentistry. If there is a question on side effects, it will be around dentistry. For example, somebody said calcitonin. Let us see what are the side effects of calcitonin. Let's go through them. Okay, where it is. What do you think in the side effects is relevant to dentistry? Dyschezia, facial flushing, tingling on the hands, but as he said, nausea and vomiting is also seen. But the chances of gastritis and GERD are very high with bisphosphonates. What's going on? Somebody is snoring? Oh, okay. Right, let's go to the next one. Let's go to the, I'm sorry, I'm scrolling up and down because I don't want to torture you with every slide. Let's just focus exam-based stuff, right? Okay, let's go to the indications of these drugs. So why are these bisphosphonates, how are they going to benefit these patients? Here are some of the indications of bisphosphonates. How do they benefit your patients?
Which patients? Which patients?
Louder.
Increase bone density.
Yes, increasing bone density. Yes, that's good answer. What else?
Prevent the breakdown of bone.
Yes, that is similar to increasing bone density. So patients, they suffer from bone pain. Cancer patients, they have extreme bone pain. Then bisphosphonates are given to relieve them from that. Also, because of the metastasis of the cancers into the bones, the bone is getting resorbed. Patients are having hypercalcemia. So to stop bone resorption so that patients can be relieved from symptoms of hypercalcemia. Okay, let's take a look at the mechanism. Pay attention and you must tell me what's the mechanism of action of these drugs. Take a look and tell me.
Blocks the osteoclasts from binding to the bone so they can't get activated and resorb the bone.
What's written on the slide?
Because it blocks the binding because it destroys the Russian border.
So it is inhibiting the expression of rank ligands. Always pay attention whether it's stimulating rank ligands or inhibiting rank ligands. Anything that will stimulate rank ligands will cause bone resorption. And the other one at the top, sorry, not at the top, below, it says inhibits mevalonate pathway. Mevalonate pathway is the other name for cholesterol pathway. And two enzymes are inhibited that are called phenyl and geranyl pyrophosphate. Okay? Geranyl and farnesyl pyrophosphate. Any questions? Let's keep going down. Let's go to the pharmacokinetics. Pharmacokinetics of bisphosphonates are equally important. What is oral bioavailability? What is oral bioavailability?
50%.
The oral bioavailability of a drug is the amount of drug that is available at the site of action. That is the amount of drug that reaches in the unchanged form in the systemic circulation. So, the absorption in the GI tract and the metabolism in the liver impact the amount of drug that reaches the systemic circulation. So, in the GI tract, what do you think? A drug that is highly lipid soluble will pass across the cells of the GI lining, or a drug that is not lipid soluble will pass?
Highly lipid soluble.
You can say louder.
Highly lipid soluble.
Highly lipid soluble will pass quickly across the GI lining. But these drugs, they are poorly lipophilic. That is why their absorption is not very good. Or their oral bioavailability is not very high. So these drugs, they go into the blood, then quickly they are taken up by the bone. Anybody can tell me what is the bioavailability of a drug that is given IV?
100%.
100%. Good answer. Okay, what do you see in the case? You think this patient has some sort of infection? Did the patient suffer from infection?
No.
Read it and tell me.
No mucosal lesions or infective processes were detected.
Patient was given antibiotic therapy. When are antibiotics given?
Infection.
So a patient of osteonecrosis can get infections. Okay? Patient of osteonecrosis can get bone pain. But do you think they get always the bone pain, or it can be silent as well? Bronch or bronch can occur silent as well.
It's usually painful.
It can occur silent as well. It's not that always they will have bone pain. They may not. They may present with infection or they may not. They may have bone pain or they may not. They may present with loosening of teeth.
So that is osteoporosis.
Apart from bisphosphonates, which was the other drug I said the other day can cause osteonecrosis?
Denosumab.
Say it louder for your friends.
Denosumab.
Yes, denosumab, right? Are you aware of drug holiday? Do you remember from our previous lecture? What is drug holiday?
Taking a break from a drug you take
Yes,
routinely.
say it louder.
Taking a break from a drug that's taken routinely.
Okay, good. So when the drug holiday is given, for how long the drug holiday is given? It can be few days, it can be few months, it can be few years. It's a planned therapeutic strategy. Yes, please.
You say it's drug holiday? How do you spell that? Like holiday?
Drug holiday. Oh, my Korean accent. Sorry about that. Holiday.
How do you spell it?
How would you say it? Let me learn from
Holiday.
Holiday.
Like Christmas is a holiday.
Okay, I'll slowly change. It will take me a while. So, should you be using vasoconstrictors in patients who are on bisphosphonate therapy along with their local anesthetics? No. You think IV bisphosphonates are more safe or oral ones? Oral ones, yes. We talked about that. So SERMs are selective estrogen receptor modulators. Their names are Loxafen and Bazidoxafen. They are used for treatment and prevention of osteoporosis. In our body, estrogen receptors are present all around, especially in the breast tissue, in the bones, and in the endometrial tissue. But their forms and types are different all around the body. Therefore, different drugs, either they act as agonists, partial agonists, antagonists on these different areas. But let's focus on the SERMs. They are agonists on the bone tissue and antagonists on the breast tissue. That is why sometimes they may be used for cancers of the breast, but our focus today is osteoporosis. Do they have any action on the uterus? No, they don't. That is why they are good drugs for patients who are suffering from osteoporosis. They are agonists on the bone tissue and they are antagonists on the breast mass. How is it different? How are they different from women who are on HRT, hormone replacement therapy? What do you understand by that? HRT comprises of, what are the two hormones that are given in hormone replacement therapy? Estrogens and progesterones. And why are progesterones added? Because during a cycle, menstrual cycle, for the first 15 days under the effect of estrogens, endometrial lining is building up. Then to stop the building up of the endometrial lining, progesterones are released in the body. So that kind of stops the building up of the endometrial lining, and then there is a progesterone withdrawal when there is menstrual cycle. But when progesterones are given along with estrogens, they do not let the development of endometrial cancers, right? Okay, we have the indications put up here on this slide for HRT. The indications are loss of bone, if there is loss of bone density, if there is urogenital atrophy, or there are vasomotor symptoms, hot flushes and profuse sweating. Then females are given HRT around menopausal age. But we talked about it that there is a risk of endometrial cancers or breast cancers, and there is a risk of thromboembolism. What is thromboembolism?
A blood clot that breaks loose in the blood vessel.
Blood clot in the veins. Deep vein thrombosis is called thromboembolism. When the blood clots, it's called thrombosis. If it breaks down, goes into the other parts of the body. So from the leg, it's going on, it goes to the heart from the inferior vena cava, then it travels around the heart, then it goes into the artery. So that's an emboli. The part that is traveling from one part to another. Okay. So let me, suppose there's a patient in your clinic and you're taking a history and the patient says, "Doctor, I was admitted in the hospital because of flank pain." What do you understand by flank?
Like their side.
What part of your body is the flank? Just this part. Not the side, not the front, just the side of your That's where the kidneys are. If somebody is having a flank pain, that means there is a renal pain. So, suppose there is a stone in the uterus. Suppose there is a stone in the uterus in a male patient. What type of symptoms will you expect? Ureters.
Oh,
Oh, I'm sorry. I said uterus. I'm sorry, ureters. Yeah. Men would not have a uterus, right? So, suppose there is a stone in the ureters. I was trying to make it simpler for you, for the dental students, the case to be simpler for you. So, in the ureters, there is a stone. How will it reflect in the clinic or in the patient? There will be severe pain. Severe pain, patients are admitted to the hospital, they are given painkillers, there is hydration therapy that is given. You don't want to bother about that. But suppose the patient gives you a history of renal stones, it's likely that that patient has higher amounts of calcium in the body, because renal stones are also caused by high amounts of calcium in the body. But my question to you is, you know what, I get very distracted. I want to really know from both of you, what is the discussion going on?
We're just trying to prepare for our exam coming up in an hour or so.
And at the same time, you want to listen to this one?
Sorry, we'll stop talking.
So suppose there is suppose there is a patient who is consuming high amounts of calcium. Do you think that patient can have hypercalcemia?
Yes.
Invariably, hypercalcemia does not occur from diet.
No.
Okay? It occurs from higher amounts of PTH. It does not occur from diet. Why? Because our body will throw out the excess calcium via feces. It combines with bile. Only the required amounts are absorbed in the body. But we did talk that excess amounts of vitamin D when taken can cause toxicity. So do you think somebody who is taking excess amounts of vitamin D can have hypercalcemia?
Yes.
So keep that in mind. It could be, if I throw up a case like that, it will be around vitamin D, excess intake or hypercalcemia. Last question, then you are free to go. What's the time?
11:43.
Okay, sorry about taking so long. Have you heard about proton pump inhibitors? Can you name one?
Omeprazole.
Omeprazole. When will you use omeprazole?
Third.
What type of patients?
Third.
Gastric ulcers. Especially you will use when you want to give them painkillers like NSAIDs. Like ibuprofen, you've read about that, right? All those NSAIDs. Is there any NSAID you know of that is given especially in patients of GERD so that they do not get GERD symptoms? You have to answer this and then go.
Can you repeat the question?
Yes. Okay, there is a patient of GERD in your clinic. You want to give them a painkiller. Patient has liver toxicity. You cannot give them acetaminophen. And you do not want to give the patient opioids. So your option is to give an NSAID. Patient has GERD symptoms. What type of NSAID can you give?
Yeah, selective COX-2.
Yes, selective COX-2, and there is a drug. What's the name of the drug? Celecoxib. Good. When do you not give celecoxib?
The cardiovascular disease.
If the patient is having cardiovascular symptoms. So in that patient, you want to give aspirin or ibuprofen, and along with that, you may want to give omeprazole, PPS, right? If you have to give, then you give these drugs. These drugs are known to cause osteoporosis if given for long term because they inhibit the absorption of calcium. So if there is a patient who is having hyperkalemia, patients of hyperkalemia are treated with calcium, sodium bicarbonate. You don't have to worry about that, but remember calcium is used IV in these patients to treat hyperkalemia. So in the uses of calcium salts, we have their cardiac dysrhythmias can be caused by severe hyperkalemia. That IV means calcium is given IV. I just wanted to clarify that. And teriparatide is a drug that is given as, take a look yourself. Is it given oral, subcutaneous, continuous infusions, or once daily injections? Subcutaneous as once daily injections, so that the peaks and the troughs are created for the parathyroid hormone levels in the body, not given continuously. Okay? I wish you very good luck. Sorry to keep you waiting, but I wanted to help you with the questions because my questions are always considered tough and I really don't know how to make them easy. I thought this is the best way. Okay? Good luck. Enjoy your day.